Okay, so welcome everyone. We're so glad to have you here and glad to have you joining us today. My name is Caitlin Graves. I'm a social worker at Northwest Medical Specialties, and I am so excited to be here, and I'm a member of Cancer Support Community. So just for those who are newer, you've probably heard this, we kind of go over our partnership with Cancer Support Community at all of these events, but Cancer Support Community is a worldwide nonprofit that provides resources and support to anyone who's been touched by cancer. And so with that, our partnership allows us to bring these kind of educational workshops. We do social events, we have resources and support groups. So there's a team of us, and we're just so grateful to be able to provide this to you guys in the community. And so that's just kind of just a little bit about Cancer Support Community. So we're glad to have you here, and today we're talking about making treatment decisions with Donna Banks, and we're so happy that she is going to be presenting for us. Before I introduce Donna, I just want to go over a few housekeeping things. So we definitely ask that everyone stay muted, and that you keep yourselves muted for the duration of the presentation. That just kind of helps limit any background interference. We have a lot of time at the end to answer questions. So if you do have a question that comes up, definitely utilize our chat box. It should be at the bottom of your screen. You can click on that and just type in your question. Someone will be monitoring our chat box and facilitating questions at the end. For the best viewing option, we definitely recommend using speaker view, which would be the top right corner of your Zoom, and you can switch it to speaker view. And then also slides will be made available after the presentation as well. So if you are looking for those or wanting those, we'll definitely make sure that you're gonna get those at the end if you're needing them. So with that said, I think I'll go ahead and introduce Donna and just have a little bio. So Donna Banks is a breast cancer nurse navigator for Northwest Medical Specialties. She holds certifications in general oncology and breast oncology and has been a nurse navigator for 14 years. Prior to this role, she worked at Johns Hopkins Hospital working with leukemia and lymphoma patients. And Donna has been an RN for 18 years and finds her work rewarding in many ways. She often finds herself saying what an honor it is to help patients through one of the toughest journeys in their life. So without further ado, I'm going to bring on Donna, and she's going to take it over.
Thanks, Caitlin. Good afternoon, everyone. It's a pleasure to be here. Thank you. So I feel like a little more housekeeping stuff here. So the slides that are part of this presentation, they've been reviewed by Dr. LeBlanc April of this year. Next slide. The program, it's been developed by Cancer Support Community. The content is developed independently, and then we have it reviewed by outside sources. We have control over the content. The program was sponsored by our Pfizer colleagues, and I was asked by our local CSC, Cancer Support Community folks, to join this program today, so thank you. Next slide, go ahead. I do not have any disclosures, so let's get into it. Objectives. So several things that hopefully you guys will kind of take. Well, you are home. I was gonna say take home messages, but you guys are everyone's home, right? Learn how to recognize your treatment needs, how to respond, knowing the questions to ask, being knowledgeable about your cancer and the treatment options, building your support system. There'll be information about for caregivers and just in general making choices that are right for you, how to kind of figure that out. So a lot to talk about. Next slide. So newly diagnosed tips. Okay, so you or your loved one may have a diagnosis of cancer, but that does not mean cancer defines you. You might be you're a grandma, you're a teacher, you're a mom, you're someone's best friend, right? You are a lot of things, but cancer does not define who you are, right? It's a part of your journey, in life, I suppose, but it is not. It's not. This should not be the center focus of your life. So a couple of things when you're newly diagnosed, educating yourself. So there's that old, I don't know, I think when I was a kid, there was like a commercial on TV, knowledge is power. And I used to kind of laugh at it, but it is really true. Being knowledgeable about your type of cancer, and I don't mean, oh, I have breast cancer or I have lung cancer, that there's much more to it. We'll get into that. But educating yourself about the type of cancer you have and the treatment, it will help you feel a sense of control. Getting support, so whether that's friends, family, your pastor, the checkout lady at Safeway, building your support system, your tribe, really essential here. And then having hope and courage. So I think that whether you believe in a higher power or not, I feel like when people are diagnosed with cancer, courage is kind of given unto them. I feel like you already have it. You might not know it's there. You might not feel it and see it every day, but it is there for sure. I have not personally been through cancer, but I have worked with cancer patients for 18 years, I think. So I've seen thousands of people go through this. You can't get through this without having courage. Now, hope. I actually, when I was looking at some of the slides last night, I actually looked up the definition of hope, and a couple of things came up. Hope, a feeling of expectation and desire for a certain thing to happen. Okay, sure. But then I found some other kind of definitions, if you will, talking about hope. So hope is the only thing stronger than fear. I like that better. And then hope, the anchor of the soul. What keeps you going no matter what? And I feel like cancer patients, their caregivers, you need that, you have that. It's what helps you roll out of bed in the morning. So I think hope and courage are needed, and I think cancer patients, it's in you, it's there. Sometimes it's harder to find on some days. Okay, next slide. So some treatment planning basics. So here are some things your medical team will discuss with you. So your age. Now, I have seen 90-year-olds that function, look like, function like 50-year-olds. I've seen 30-year-olds who function and, their physical age is that maybe of a 60 or 70-year-old. So truly, when people say age, there's your chronological age, there's truly what your age is in years, but physically, mentally, emotionally, what is your age? So that's something that will play a part in your treatment. Your point in life, including family life and work. So are you newly diagnosed and you just got married and you want to start a family? So do we need to involve our fertility colleagues? Are you, your work life? Did you just start a new job and then you were diagnosed with cancer? I see that a lot. Your overall health. So I've never seen a cancer patient newly diagnosed with no other issues going on, right? Everyone has something going on, whether it's physical conditions, emotionally, what do you have going on? So all kinds of things. We have to look at the whole picture. What are your expectations for treatment? That's huge. We're going to talk about that some more. What are your goals and expectations? Really dependent upon your type of cancer, your stage of cancer. We'll get into that a little more. Your available resources and support systems. So that is, your family and friends, but also things below, like, can you get to and from treatment? Can you afford, the gas? Do you have a car? Things like that. We'll get to additional questions later, but next slide, please. Empowerment approach. So setting your goals, planning a strategy for each goal. We're going to talk more about goals in several slides later, but your goals, they can change throughout your cancer journey depending on a number of things. How is your cancer responding to treatment? What stage is your cancer? You could have a goal of, I just want to make it to church on Sundays. That's my goal. Or I want to go and spend time with my grandchild. How can we plan for those goals? And again, we'll be talking about this throughout, is communicating with your team, your medical team, about what your goals are, what your values are, and how can we make that work for you. Finding resources, so things like, well, and I kind of want to have a caveat here. Some of the things I guess maybe I'll talk about is kind of COVID aside, but finding resources. So things like support groups. Now things are virtual like this, and that's fantastic. There are so many programs out there for financial support. Talking to your social workers and your navigators about those resources. I feel like you just have to know to ask, because there's so much help out there. Again, the next thing, ask for help. Don't do this alone. I think, there are so many people that want to help cancer patients through the process. So not only ask for help, but accept the help, because people, especially family and friends, they want to help. They may not know how to help, but please accept and take action on your strategy for trying to get those goals accomplished. Next slide, please. So shared decision making. Treatment decision making is shared decision making. So what this means is, it's kind of like if you think of a bicycle wheel, and the hub at the middle in the center, that's you. That's the patient. You're in the middle. We're focused on you. All those spokes around, that's maybe your medical oncologist, your radiation doctor, your surgeon, your social worker, your primary care physician. Lots of people kind of in the outside there, with you in the middle, making decisions about care, making treatment recommendations, things like that. So it is you, it is your healthcare team discussing your values, your goals, what's going on with you. Again, it's all, I usually tell patients, this is a time in your life when the focus is on you. And that's not easy for a lot of people. Like I said in the previous slide, accepting help, this is a time I kind of say to be selfish and just make this about you, make sure your needs are heard. So shared decision making is you and your team of doctors making decisions together. It's not just, well, the one doctor says this and this is how it's going to be, right? You are a part of that decision making. So it's a team approach. Next slide, please. So setting your goals. There's so many different things here. So physical goals, emotional, sexual health, well-being, all different things here. So, if you are a prostate patient, a breast patient where certain organs are being affected. I work with breast patients primarily. And when we're talking about surgery, on the breasts, the surgeons that I work with, they're always very, they're always very kind of sure that they bring up lobectomy, only removing the cancer, keeping the breast sort of intact, versus mastectomy, the nipples gone. How is that going to affect your sexual health? That can definitely be an issue. Physical, emotional, physically. So I've had several patients who are not only marathon runners, triathletes, and it's interesting, several times when making a decision about surgery, and not just runners, but real athletic women, they've chosen to have double mastectomies simply because physically, they're runners, they're athletes, they're constantly going. It was easier for them. One of their goals was, I'm a runner. It's so much easier if I'm just flat chested. My life, would be easier. And so several patients I've had, their goals were to continue running, making it easier. They decided to have double mastectomies for that reason alone. So what are your goals? What are your values? Family and social relationships. So what's going on with, everyone's who's in your tribe, who's in your circle? Are you a grandmother and you watch your grandkids once a week? Do you want to, if you want to continue doing that? What's going on? Are you newly married? Are you trying to plan a family? work, next thing, work, school. So do you need to continue working? Usually that's, I mean, it's not funny, but most people who are working need to be working, whether it's, financially or because of insurance. Are you a single mom, 2 kids, and you are the breadwinner? You have the insurance. So how can we make that work? I've had several patients, especially, well, now with COVID, usually through all my years, thankfully, the majority of the time when patients will talk to their supervisors and bosses about what's actually going on with them, the majority of the time, I've had patients tell me that their supervisor is understanding, and maybe if you have a physical job. I've had several patients work at like Lowe's and Home Depot and those kind of places, and their job was physical, and they figured out a way for them to maybe do the cash register for a while or whatever it is, while they're in treatment, so that they can continue working, maintaining that insurance. So what can we do to adjust your job? Or if you're in school, if you're doing remote, if you're if it's not COVID times again, you're going to school, well, can you do it? Can you go to school remotely? All kinds of things. Are you getting the help you need at home? Again, talking to social workers, navigators. There are groups out there who will come in, and if you qualify and apply, that will come and clean your home. And that might be a control issue. I feel like some women patients that I work with, they don't want anyone, they want it done their way. And so, there may be a little bit of control there, but are you getting the help that you need at home? Are you accepting the help? Maybe that might be another issue too. Next slide, please. Community involvement. So, are you someone that volunteers at the soup kitchen once a week? Are you still able to, if you go to church, whatever your spiritual beliefs are you able to continue doing that? Can your pastor come, again, COVID aside, or even with COVID, can your pastor come visit you in your home? How can we make things work? What are your goals? What things in your life are valuable to you? Because I've had usually I've been working from home myself ever since March, and usually I am in with patients during their first meetings with surgeons and oncologists and different members of the team. And they will spend time with the patient, obviously, and go over the diagnosis, the treatment, and then I will stay with the patients afterwards. And patients will tell me, well, the doctor wants to start treatment on this day, or surgery's on this day, but I had this trip plan, but I didn't want to say anything. Or I have this commitment or that commitment, but I didn't want to say anything. And I'm always telling patients, if it's important to you, if it's a goal that you have, or it's something that's valuable to you, please tell a team member, whether that's your nurse navigator or patient navigator, whoever you have that trusting relationship with. And please tell your doctor, because if it's something that's important to you, it's important to us, and we can potentially make your whatever it is that's important to you. We can make it work, not all the time, but next slide, please. So values. So it's important that you think about what values you have in your life. So some of those can be, I value being active with my family, again, being healthy enough to attend. Again, it could be a church function, it could be just doing the grocery shopping maybe, or I value having few side effects, and I value having the best treatment no matter what. So with that, there's really, I don't think there's any cancer treatment out there that doesn't have any side effects. That would be fantastic if that was the case, then that that everything worked 100%. A lot of it is about balancing, what is it going to kind of do for me, or what should this treatment, how will this benefit me, versus what are my side effects going to be? And that's, of course, the discussion with the physician. I think of this patient from a long time ago. She was a cellist, so she played the cello. It wasn't her profession, but it was her passion, something she kind of did on the side. She was diagnosed with breast cancer, and playing the cello was it was something that filled her soul, right? And so it was something that she was not okay with not being able to do. And so as a cellist, I've had cellists and harpists and pianists, so really need your sensation in your fingers, right? And there are several other jobs that, of course, you need to use your hands. But this patient, she talked to her oncologist, and I think I was in the room at the time, and she just said, I will not accept a treatment where numbness and tingling is going to be a side effect. She just laid it out there. And I was so proud of her. It was giving me chills to think about it. And so her doctor she prescribed a regimen that, that type of chemotherapy was not in the treatment plan, and she was able to continue on with her cello. So bringing things up that are important to you, really important. I value having the best treatment no matter what. Sometimes I feel like maybe we just assume that that's the case. Not always. Again, really depends on your type of cancer and the stage. I value being part of a clinical trial to advance science. So a lot of the oncologists in our community, they are aware and definitely into clinical trials. So usually they would bring it up to you if you are eligible. But it would be, I've been in enough consults with patients, like thousands of them probably. I haven't seen patients very often bring up this question. But I think that's would be awesome if patients knew to ask, to be involved in a clinical trial. But usually the oncologist will know beforehand. A lot of times if the office that you're receiving care at, if they have a clinical trial or a research department, your chart will have already been reviewed for clinical trials before you even step foot in the office. So that information is being looked at no matter what. Again, if the practice you're involved with participates in research, but usually the doctor will bring it up to you. So next slide, please. So helpful hints. The cancer journey has many decision points along the way, for sure. Some helpful tips. So break the process into smaller bites, one step at a time. Okay, so I tell patients this probably on a daily basis. This made me, when I was reviewing the slides again, I thought of something that happened with my daughter. So I have two kids. Two daughters, one's 10 and one is 7. And the 10-year-old, she had an assignment to memorize a 16-line Shakespeare, it was a monologue, Shakespeare, and she looked at it and she was like, how am I gonna do this in like a week? Like how, there's no way. And she was looking at it as 16 lines, how am I gonna do this? And I remember saying to her, no, you're gonna break it down. You're gonna look at maybe 2 lines a night, memorize, small steps. So when I was looking at the slides, I kind of thought of that. When you're newly diagnosed with any kind of cancer, you're going to meet with several different physicians, specialists. There's going to be potentially surgery, chemo, radiation, hormone therapy, immunotherapy, so many transplants, so many different things. Sometimes those things happen concurrently together, sometimes not usually. So just breaking things down into, okay, I was just diagnosed, I have this appointment. Sometimes taking it literally one day at a time, or one test at a time, or whatever it is, taking it into smaller bites will help you emotionally, psychologically, even physically. So long-winded discussion about breaking things down, but I tell this to patients constantly. Whether you need to look at it day by day, what do I have going on? Or if you can look at it in a week, fine, but making it smaller. Locate yourself in the process, thinking about your goals, your life, like where are you right now? I'm slated to have 18, cycles of chemo. Okay, I'm on week 9. Knowing kind of where you are, where you're going, looking ahead just a little bit, not too much because we want to stay in the present, but knowing, okay, where am I right now? Work with your doctor to create a written treatment plan. I'm always telling patients to write things down. I'm usually telling them to write things down in pencil because things change a lot, especially with your calendar. But having something paper to refer back to is fantastic, whether it's something printed. I email patients a lot with just, this is what the doctor said kind of thing with the treatment plan, just so you can go back and read it. Next slide, please. Just doing a little time check because I can go off on tangents. So understanding your diagnosis. Okay, so ask your doctor to tell you exactly what kind of cancer is and for them to write it down. If you don't understand, please ask questions. So again, it's not just I have lung cancer, I have colon cancer, I have breast cancer. We are so much more advanced now that we know so much more about whatever the type of cancer is. Again, I focus on breast, so I have estrogen fed, I have HER2 negative, HER2 positive, blah, 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 ductal, this and that. Ask for the details, really, ask for the details. Ask for a copy of your pathology report. So whether you're gonna tuck it into a folder and put it away somewhere, fine, but it is really important for you to have that pathology report with all those details of your cancer, just in case, patients move all the time, if you move somewhere or you change providers or whatever it is, that path report is kind of like your passport. Ask your doctor what they base their treatments on. Talk to your nurses about it. So, or what they base their treatment recommendations on. There's all kinds of things here. We're going to talk about guidelines and pathways a little later. But there are set kind of standards of care, regimens that have been proven to have the best outcomes. There's an oncologist I work with. One time, she goes to conferences, all the time, and there's this really big breast conference in San Antonio every year. And I remember several years ago, gosh, this must be 10 years ago or something. She came back with just something new, this new data that came out of this conference, and it was huge data. Just knew the latest and greatest with this breast cancer treatment. And she came back, and that's what she started doing. That's what she started recommending to her patients. So she literally came back from a conference in December, and it changed her practice. Because the data was huge that it was beneficial to patients. So sometimes asking, is this based on, an NCCN guideline? We'll talk about NCCN guidelines later. Is this from a paper you read, a conference you went to? What are these recommendations based on? Talking to other people who have had cancer. Oh, sorry, it's okay. So talking to other people who have had cancer. So I hook up patients a lot together. But I always caution patients, and a lot of times people know, but sometimes they don't. You can have 10 patients in a row, all with breast cancer. It's kind of like you can have 10 apples lined up, but one's a Granny Smith and one's a Macintosh and one's this, that, and the other thing. So just because you have breast cancer and she has breast cancer, your treatments can be completely different. And so I like when patients talk to each other, especially for the emotional side of things. Like I've said, I have not been through cancer, so I can't relate 100% completely. But for that emotional support, hooking up with another patient is great, but just not comparing, because most of the time it's not. It might be apples to apples, but you might have a Granny Smith and she might have a Macintosh. It's just next slide, please. So again, questions to ask about your cancer diagnosis. What type of cancer? Again, I don't want the generic answer, oh, I have breast cancer. I want to know, is it ductal, lobular? What's the estrogen status? So many different pieces of information that you should have about your type of cancer. What stage is my cancer and what does it mean? So that's huge. In general, stage 1, 2, and 3, we are looking at cure for these patients. Stage 4, tends to be a little different. Stage 4, when it's gone kind of outside of the box, it has traveled to another place in the body. Having that conversation, I've been an oncology nurse for 18 years, and I have several oncologists that admit it. They'll talk to me about it. They definitely have trouble having those conversations with stage 4 patients. So what does it mean? If I'm stage 4, what exactly does that mean? An important conversation to have. What symptoms of cancer might I experience? What symptoms of treatment might I experience? Is pain expected? Numbness and tingling, whatever it is. Usually in any practice that I've ever been involved with, patients always meet with a nurse practitioner or a PA, or even the physician themselves, to do some treatment teaching before we start you on something. We're going to educate you about it. So you should definitely learn about side effects, but symptoms of cancer, again, please tell me what I can expect from this here. What types of tests will I need? Usually they're very forthcoming about that information. You're ordering a CAT scan. Should I be having a PET scan, bone scan, this, that, the other thing? Like I said, usually, so I work with several different oncologists, and they all kind of work differently. Some are a little more, I don't want to say forthcoming, but just more kind of talkative and say, oh, I'm ordering this, I'm ordering that. Da, da. Sometimes it goes right over patients' heads. I just got off the phone with a patient before this meeting, 44-year-old, great lady. And she met with her oncologist, and I knew what she needed to have done, but she was really confused about it. So making sure you get that information either written down when you're in the appointment, so just knowing what tests are needed for you. And where can I get a second opinion? So again, being a nurse navigator, patients get really comfortable, I guess, talking with me. And so they might feel guilty or embarrassed or sad or whatever bad about talking to their doctor about a second opinion, because I feel like patients think that it makes them feel bad or something, but I just say, don't even mess with that. If you want a second opinion, that's for you. If that's going to help you sleep better at night, if it's going to help you process everything, go and get a second opinion. And definitely, again, if you're not comfortable, believe me, your physicians, it's not that they don't care, but I mean, they understand why you would like to get a second opinion. So don't hesitate to ask. I get patients all the time asking me about it. So maybe ask your nurse navigator or a patient navigator about a second opinion if you feel like you need that. Next slide, please. Choosing your healthcare team. So your choice of doctor and cancer center depends on a couple of things. So your cancer type and stage. So there are definitely some cancers, acute leukemics who maybe need to go up to a large cancer center and be inpatient receiving chemotherapy for weeks and weeks on end. Most cancers these days can be treated very well at more local, smaller institutions. Again, it can depend on your stage, your personal preference. So I guess some patients maybe prefer being at kind of those larger university type institutions. I feel like I've been working with private practice for a while, and I feel like patients usually like or prefer care that's closer to home. And so again, it's your preference. Unfortunately, insurance coverage, insurance companies can definitely dictate what physicians you can see and who's in network and not in network. And oftentimes we see patients having to transfer care because of that, which stinks. Logistics, like again, transportation, distance, cost. I have patients that they think maybe, they think, or they have other people telling them that they need to go to the big universities for their care. And usually it's just not, it's due to transportation and the cost of transportation, it's not usually what they end up doing. But where you live, where you have to go for treatment, oftentimes some of these treatments are daily, so it's just logistics of getting to and from your treatment that can depend on where you'll have treatment. So next slide, please. So everyone probably recognizes all of these names. Medical oncologists, they're the ones that are going to talk to you about chemos and immunotherapy and all kinds of systemic treatments, treatment that affects the whole body. Nurses, you'll meet many different nurses throughout this process. I'm a nurse navigator. There are infusion nurses, inpatient nurses, all kinds. Surgeons, surgical oncologists. So a surgical oncologist is a surgeon who has additional training in oncology, cancer surgery. Pathologists, those are the people that look at your cancer tissue under the microscope and give us a diagnosis. Radiologists, people always confuse radiologist and radiation oncologist. So radiologists, they are the physicians that are looking at those scans, the pictures, the mammogram, the CAT scan, the PET scan. They are the very, very well-trained eyes that are looking at your scans and telling us what they see. Radiation oncologists, they are responsible for discussing and recommending various types of radiation with you. That's part of your plan. And dosimetrists, radiation therapists, the physicists, they all play a role in planning and dosing your radiation treatment. Your GP, your PCP, GP, your general practitioner, we don't want to lose them in the midst of everything else that's going on because, again, cancer does not define you. And so you may have other things going on. And so making sure your general practitioner is involved all throughout. Social workers, I love social workers. I always have. They are wonderful angels put on this earth to help patients also get through various, disease processes. But those that work with cancer patients are very special and can help with myriad of issues you might have. Next slide, please. So you're a pharmacist. I have patients where their pharmacist becomes their best friend because they're going to the pharmacy a lot to pick up various prescriptions. Psychiatrist and psychologist. I'll throw in there mental health counselor. I wish that every cancer program, be it small or large, had a mental health counselor or a psychiatrist kind of on staff because I feel like everyone could benefit from that. I'll just leave it at that. Dietitian. So, are you a esophageal patient, needing radiation and the various side effects that come with that, or even just being on chemotherapy. We regularly refer patients to dietitians due to not only taste changes, but just all kinds of different issues that happen when you're on any kind of cancer treatment. We need to make sure that your oral intake is, and your nutritional needs are being met. Plastic surgeon in breast cancer. So I work with plastic surgeons a lot. And I think we all, probably are familiar with what plastic surgeons would do. Rehabilitation. So rehab usually would happen after maybe a surgery is done, or you've been on chemotherapy or radiation and your range of motion has been affected, or just if you have any number of physical issues going on. A lot of programs in the country are looking at what's called kind of prehab. So doing an assessment of your physical functioning before we even start with chemotherapy, radiation, surgery, whatever it is, to get a baseline of where you're at and to be kind of included along the way as you're having all these different treatments. And they are very helpful with dealing with all kinds of things, anything from neuropathies, gait, walking steadily, just all different, and strength training, just all kinds of different things. They can help with home health if you need home health. Hospice care, palliative and hospice care. I think we're going to talk about that a little bit. I always feel like both of those services, palliative and hospice care, are always introduced too late, but that's maybe another thing. And your clergy, again, whatever your beliefs are, making sure they're part of your team. Next slide, please. So preparing for your visit, and any visit, not just a new patient appointment, making sure you have your questions written down. That's really helpful for the physician. You know, they're going to probably have their spiel to give you. Sometimes your questions will be already answered when they're done, but making sure that those questions that you have are answered, because 9 times out of 10, if you don't write it down, if you're like me and you don't write it down, you're going to forget. So writing down the answers to the questions, that's also really helpful. Don't record the visit without asking and discussing with your doctor. Yeah, that's true. There's a surgeon that I work with, and several times patients have asked to record the visit, and she's agreeable to that, but she says, you know what, let's, instead of recording like an hour and a half conversation that someone needs to kind of, you know, then go through and try to listen, she says, how about we do the appointment like normal, and then she will record like a 5-minute summary on the patient's phone of what the whole appointment was about, because they can summarize it in like 5 minutes, and that's much easier than just recording like a 90-minute appointment. Then you have to kind of sift through the whole thing. So that's a good. I always thought that was a good idea, just to kind of record just summary from the doctor. Bringing a family member or friend, I always am telling patients that for the big appointments, you know, the initial consults, the teaching appointments, the treatment teaching appointments, appointments where big decisions might be made, or appointments where, you know, you're waiting for these PET scan results, whatever it is, having someone with you. And in our COVID times now, a lot of times we're seeing patients on Zoom, making sure that friends or family are connected that way if you want them present. And of course, as always, tell your whole team, you know, your team should be aware of what medications you're taking, whether it's over the counter, supplements. Again, back to a couple of slides ago, your team is made up of a lot of different doctors, and you know, this one is prescribing this one's prescribing this. So we need to kind of have an idea of everything that you're on. You know, the naturopath might be prescribing something else. So we really need to have a good idea of what you are taking every day. Next slide, please. So what you can do, trying to stay focused, back to, you know, don't try to memorize the whole Shakespeare monologue in one day. Trying to take things one step at a time. You don't usually have to make a lot of treatment decisions at once. Break it down. Asked to sit down with a financial counselor. Yes, this is huge. Most institutions, again, whether they large or small, they will have social workers, financial counselors that can help you figure out, you know, what is this going to cost me? Not only what is this going to cost, what is my insurance going to cover, but what programs are out there to help me, whether that's programs helping with your electric bill, or with medications, chemotherapies, whatever it is. Remember, you always have to ask. Just know to ask, to sit down with someone. Understand that things will change, and how you might feel about things will change. Usually, you know, cancer is a journey. It's not usually, well, you know, I have this one treatment and I'm done. You know, it's usually several different things, because we've come so far with the treatment, the diagnosis and the treatment of all cancers, that it's very involved. And this is why there are lay navigators, patient navigators, nurse navigators, that we're all here trying to help you along the process. So understanding that, you know, maybe you're starting chemotherapy. Again, my reference is usually breast cancer patients. You start out, you're having chemotherapy first as part of your treatment plan. And right when you start, you say to yourself, I've seen this so many times, when it's time for surgery, I'm having a mastectomy. I'm having my breast removed. And then you kind of have all this time to think about it. You're going through chemo for 3 or 4 months. And by the time you're ready for surgery, you've had so much time to think about it and really process things that you say, you know what, after I've, done my thinking and praying about it, and, I've educated myself from these various means, I think I'm actually going to have a lumpectomy. So things might, your feelings about things might change. Taking advantage of available resources. So again, resources as it could be anything from a friend willing to come and help mow your lawn, or someone to come and run the vacuum in your house. Take advantage of that. Say yes. Sometimes that, it might feel like losing control, but it's helping you. It's helping you. Accept the help. And again, other programs that are out there. Sorry, treatment options. Go ahead. Okay, so making a decision, factors to discuss with your doctor. Okay, so goals of treatment. Again, this is going to be based on your the stage of the type and stage of your cancer. In the early stages of cancer, usually the goal is potential cure, eradicating the body of the disease, it not coming back. That's wonderful, fantastic. Again, with stage 4 cancer, we know it has already spread elsewhere. The goals are usually a little different there. So discussing with your physician, what's the purpose here? What is our end game here? Potential benefits, of course, you want to know how is this treatment that you're recommending, how is it going to benefit me? Is it going to alleviate my pain? If you are a stage 4 prostate patient and you have the cancer has spread to your bone and you have terrible hip pain, and you're meeting with the radiation doctor and they're saying, well, you have to have 10 treatments of radiation. Okay, well, what is that going to do for me? The goal would be to alleviate your pain. So just knowing what the benefits are to all these rigorous treatments that will be recommended. That kind of goes hand in hand with type and severity of side effects. Again, usually we're teaching you in separate appointments about side effects of treatment, writing things down, again, making sure you have your support folks, your tribe with you to know what to expect. Reasons behind treatment choice, again, is this part of a guideline, that you're recommending treatment because this is a guideline? Is this you would know if you're on a clinical trial, of course. Is this part of a clinical trial? Why is this being recommended? Where are you getting your data from? The cost of treatment, again, I hate that that's an issue, but knowing there's something called the financial toxicity of cancer, and it's awful. So knowing upfront about potential costs and potential programs out there that might be able to help you with those costs is huge. Next slide, please. Okay, so guidelines versus pathways. There's a focus on developing evidence-based standards of care. So what that means is evidence is like data, like proof that we know this is the way to go. This is the best treatment option for the best outcome. And so there's a huge push, and it's been for a long time now, evidence-based care. So we don't just do things and recommend things for the heck of it. We're not just kind of willy-nilly about things. So guidelines and pathways help doctors and patients make informed treatment decisions. And there's a difference between guidelines versus pathways. So we'll talk about that. Next slide, please. So guidelines are based on a cancer type, a cancer, so again, not just lung cancer, breast cancer, colon cancer. When we break it down even further, okay, so what type of breast cancer, what subtype of this or that cancer? the genomic profile. So it usually will depend on the stage of your cancer, the type of your cancer, genomic profiling of the tumor. That's where your cancer tissue is sent off to a fancy lab, and they run a huge analysis on the tumor, looking for genetic markers, different sort of targets, things that we can target potentially to reduce the growth of your cancer. And guidelines are also based on the stage of cancer. So panels consisting of cancer specialists, experts, all kinds of people are involved in developing these guidelines. And they're based on what is known to work. And cost is not really thought about when coming up with these guidelines. So the guidelines used most often in cancer are the NCCN guidelines. So it's National Comprehensive Cancer Network guidelines. What I love about NCCN is there are guidelines for all cancers, and there are kind of a provider form of guidelines where you can go in and look up and see, okay, if you have breast cancer and it's HER2 positive and this is what I should do, and it's kind of like an algorithm. NCCN has patient guidelines. So anyone can, if you just Googled, again, it's NCCN. If a layperson tried to interpret the guidelines that are more for physicians and nurses and stuff, it's kind of all just in a foreign language. Sometimes you might feel that way looking at a pathology report too. So NCCN has patient guidelines where it breaks down everything so beautifully and explains things in layman's terms. So again, back to educating yourself about your diagnosis and treatment. NCCN for patients is a huge resource for you. So that's one take-home message. NCCN for patients they're wonderful guidelines. Next slide, please. So pathways. Pathways are just a little different. They are shown to improve quality of care, ensuring patients receive proven therapies, of course, rather than unproven and expensive treatments. Pathways include preferred drug choices. So it's kind of like when I go, if I have a headache and I go into Target, I'm usually not going to go and buy the Advil, like the brand name Advil. Usually I'm going to go and buy the Target version ibuprofen, because I know they're pretty much the same thing and they're both going to relieve my headache, but the Target version is way cheaper. So similarly, with pathways, for example, again, I kind of go back to the breast cancer thing. Over 20 years ago, when the Herceptin was invented. So if you have a HER2 positive breast cancer, it's standard of care that you would receive this medicine called Herceptin. And when that drug was developed over 20 years ago, they had a patent on that drug. So recently the patent expired, and so other companies have been developing medicines that are very similar to Herceptin. They're called biosimilars. And so they do the same thing. They're just a little cheaper than we'll say, like, it's kind of like going to Target and getting the Target version of Advil. And so pathways really look at, okay, let's look at the drugs, the preferred drugs, the drugs that are going to do the same thing, give us the same bang for our buck, but it's going to be cheaper. And so we utilize pathways to help develop treatment plans, and in some cases, not all cases, but in some cases, oncologists receive financial incentives for adhering to the pathways, because it just really lowers the cost of care all around, which is good for everyone. Next slide, please. So questions to ask. Again, what is the goal of this treatment? Is this palliative? So is this, are you a stage 4 patient and the treatment that they're recommending is going to help with pain control? Or is it going to, is this regimen you're recommending going to extend my life in any way? Or are you a stage 1 patient and the goal of this treatment is to assure that, you know, your cancer does not recur, it doesn't come back? So what is the goal here? Huge thing to know about your treatment. Why are you recommending this treatment? Again, is this a standard guide? Is this a standard treatment? Is this something that you read in a paper and this has been proven to work? Is this again, is this a standard treatment? Why are you recommending this to me? What are the benefits and risks? Of course, with cancer treatment, there's a couple of doctors I work with, and one in particular always says, you know, they take the oath to do no harm when you become a physician. And with oncology, it's kind of like we're always going to do harm, right? We want to kill the cancer cells, and there's always going to be some kind of side effects. So what is the benefit and what is the risk? We need to know that. How can we prepare and manage side effects? Again, usually you're having a big treatment teaching session before we embark on any kind of treatment plan for you. So we should be telling you about how to prepare for potential side effects. And if we're not, please ask. Next slide. How often will treatment be given? That's really important. You need to know, you know, how often you're going to be coming to the facility. Where is it going to be given? You know, maybe you see me in this office, but treatment's actually somewhere else. How is the treatment given? Is it IV? Am I going to need a port? Some types of chemotherapy is given through something called an Ommaya reservoir up on top here. Is it pill form? So there's so many different ways we can give treatment. How long does it last? Is this a 6-month course? Or again, what stage is your cancer? Am I going to be on treatment for the rest of my life? Really important questions. Does the facility where I will have treatment offer resources? And most do. Usually we'll be telling you about this up front, but if not, please ask. Next slide, please. So treatment options, all kinds of things here. So chemo, radiation, surgery, targeted therapy, immunotherapy. Next slide, please. So chemo. Chemo is a treatment that involves the use of drugs to destroy cancer cells. Yes, it can be given IV, pill, all different kinds of ways. The chemotherapy, it works best on rapidly dividing cells. So cancer cells, I always kind of compare it to a work employee. So if you work at Boeing and a cancer cell is a bad employee. They don't know their job function. They don't know where they're going. They're in the lunchroom when they should be, you know, doing their job. They're bizarre. They don't work well with others. Horrible. Normal cells are like a good employee. They know what they're doing. They function in their capacity. They go to lunch when they're supposed to, things like that. So chemo works on those bad employee cells. Chemo works on rapidly dividing cells that are so they don't target anything specifically, which is why it works on rapidly dividing cells. So your hair follicles are rapidly dividing, which is why you have hair loss with most chemotherapies. Your GI tract, all these cells are rapidly dividing. So chemotherapy is not really targeted. It's kind of like bleaching, if you will, the whole body. It's systemic. Most chemotherapy does not cross the blood-brain barrier, so it's not always affecting the brain or going to the brain, but it affects every cell in your body. Next slide, please. Radiation. So radiation, it's delivered by a machine, aiming high energy rays at a specific part of your body. So radiation, it is very specific. It is targeted at the organ or the area of the body with cancer. It can be given from an external machine. It can be done it can be given internally in many different ways. It really is dependent upon the type of cancer, sometimes the stage of cancer. But again, the side effects of radiation is really dependent upon where in the body there is receiving the radiation. So very, very dependent upon what area of the body is being radiated. It is not, a lot of people confuse radiation and chemo. Radiation does not affect the entire body. It only affects the area that is being treated. So, and it can be anywhere from a week to 6 weeks long, daily treatments. So again, knowing upfront what the plan is with radiation, really important, because you need to be able to plan your life for, the next several weeks. Next slide, please. Surgery, most people know surgery. It may be the only part of treatment for you, and that's wonderful. Surgery has many different many different functions of surgery. Sometimes you need to have a little surgery for them to take a little sample of whatever is kind of looking kind of funky in there, take it out and put that under the microscope and look, so it can help us with diagnosing. Staging, do we need to sample a lymph node maybe somewhere to see if that primary tumor went somewhere else? For treatment and debulking. So I've had patients, one in particular I'm thinking of, she was a stage 4 breast patient. Her cancer was kind of sort of everywhere, but she had, she was having terrible kind of stomach area issues or symptoms. Her tumor was quite large, and it was really pushing on all kinds of things in her tummy. And so she had this debulking surgery where the surgeon went in and just removed part of the tumor. It's not that we were trying to fully resect or fully remove the cancer, because that wouldn't change long-term outcome, but it was more for her symptoms. And so once she had that surgery, her constipation and her nausea was greatly reduced. So sometimes our surgical colleagues can really help with symptom management. Reconstruction, that's plastic surgery. Sometimes for breast, obviously, if you have mastectomy, you can have reconstruction to kind of restore function or appearance of a body part after treatment. Next slide, please. So targeted therapy, so different from chemotherapy. So chemo doesn't kind of have any specific place that it's going. Targeted therapy more precisely attacks cancer cells. It targets specific genes or proteins. So again, this is very much dependent upon the type of cancer, really the details of the cancer. Targeted therapy can be given, it can be IV, it can be a pill form. So again, it really depends back to that knowledge is power, like from the beginning, knowing that the specifics of your cancer can help you kind of identify and know if targeted therapy is applicable to you. Again, back to breast cancer, HER2 positive breast cancers, about 20% are HER2 positive. It's a very specific protein expression, too much HER2 on the tumor cell. So we can give something targeted, a targeted medicine to help kind of turn that off. So targeted therapy is just different from chemotherapy. Next slide, please. Immunotherapy. So immunotherapy, it kind of wakes up your immune system to help identify and attack cancer cells. Not all cancers, even not all, again, within breast cancer, there's the Macintosh apple, the different types of within breast cancer. So not within immunotherapy is not applicable to all cancers, or even certain types of cancer it's not applicable to even certain subtypes of cancer. And immunotherapy is usually given through an IV. Next slide, please. So palliative and supportive care. Palliative care, it focuses on symptom management, pain management, stress. The goal is to improve quality of life. And so, like I said a little bit earlier, and a lot of, there was a, I don't know if it was it was just a poll taken, a conference that I was at a couple of years ago. They were talking about a poll or a study asking when oncologists talk about or bring up palliative care. And the bottom line was that it's always just too late. So palliative care, it can be a discussion point from the beginning. It is not the same as hospice. A lot of people confuse that. You can still be actively receiving treatment and palliative care at the same time. There are your oncologist, your radiation doctor, or your medical oncologist might not necessarily specialize in palliative care, but there are teams of people. There may be someone at the practice who specializes in palliative care, or maybe you can be referred out to palliative care specialists. It is hugely important for quality of life, symptom management, and definitely should be discussed from the beginning. There's so much going on in the beginning, so maybe not right at that first appointment, but we should be kind of interlacing this into our conversation, I think, at various appointments. Next slide, please. So questions to ask during treatment, lots of questions. The symptoms and side effects that are affecting me most this would be something that you hopefully will be communicating to your team, and how is it interfering with your life? What can we do to manage these symptoms? Again, I'm always telling patients, please communicate with us. If we don't know what's going on with you, what your symptoms are, what's troubling you, how this is affecting your daily life, we won't be able to help you. So please make sure that you're communicating what's going on. If it's daily, that's fine. Just please contact your care team. Could complementary therapies or supportive care help manage your symptoms? Maybe possibly a referral to a naturopath. There's so many different professionals out there who can help with symptom management, whether it's rehab, physical therapy, naturopath, psychologists, psychiatrists, all kinds of folks out there who can help. We just have to know what you're suffering. Next slide, please. Side effects, of course. You may have side effects. You probably will have side effects from your treatment. Writing them down, keeping a journal, that can help us figure out how to help you. So, if you're on chemotherapy and you're keeping track of your symptoms, and you can see that, you get your chemo on this day, and that consecutive, 3 days later, you always get really nauseous on that day. Okay, communicate that to your doctor, to your nurse. Maybe we need to bring you in on the second day for some anti-nausea medicines, and then you won't have that issue on day 3. So making sure that you write things down and communicate that to your team, because we can probably help you with it if you just let us know. Make sure you talk to your doctor about the side effects. So please be in good communication with your team. Next slide, please. So important documents for everyone, not just if you're going through cancer. Pretty much everyone should have these documents. A living will, advance directive, it lets your doctor know, or your team know, what care you want or you don't want if you are unable to speak for yourself. Power of attorney, that you will name a specific person that, again, if you are unable to make decisions for yourself, this person, also called a healthcare proxy, that person that you identify can make decisions for you. Next slide, please. Financial power of attorney, similarly, this person, though, will make financial decisions for you, again, if you are unable to do so yourself. A DNR, so do not resuscitate. And again, all these things are, you can, most things, the medical related documents you can discuss with your and should discuss with your care team. A DNR, do not resuscitate. So this would be telling your care team, or if something happened in the home, if an ambulance came, this would be telling them that you do not want any heroic measures. So no CPR, no chest compressions, if your heart were to stop, or if you were to stop breathing. A will, so a will that designates who your money, your belongings will go to once you pass away. So another thing that's important to have. Next slide, please. So for caregivers and well, caregiving, again, when you may feel rushed and it is completely overwhelming when you are first diagnosed, and you are there with your loved one who is going through cancer, helping your family member or friend, helping them to slow down, to process things, trying to process things one thing at a time. One of the surgeons I work with always says, this is not a boxing match, it is a chess game. So we have to be very meaningful about decisions that we're making, or that we're not just bam, 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 rushing into something quickly and not having thought well about it. This will give you a greater sense of peace, a sense of control, calming if you are, and again, in some cases, with some types of cancer, you don't have a tons of time to, take, days and weeks to think about things. But in cases where you can, please take the time to be thoughtful about the process. Take time to ask questions, think through what's being recommended to you, and then develop your plan along with the patient. Next slide, please. It's important to take notes for sure. I really think it's cool that that one surgeon that I work with, always willing to just kind of tape record, whether it's a tape recorder or your phone or whatever you have, just a good summary of what the appointment was about that day. Comparing notes. So I've had so many times, so many cases where I'll talk to family members after a patient appointment, and literally the daughter will have heard something completely different from the son, and I know what was said. So I'm kind of, in between there saying, well, so taking notes is really important. And as a caregiver, making sure that you have your own respite care, making sure that so they always say, you can't take care of others if you don't take care of yourself. And when you're on an airplane, putting your oxygen mask on before you put it on somebody else. So making sure that you take care of yourself so you can take care of your friend or family member. Next slide, please. So taking the next steps, being selective where you find your information. I just got off the phone with a patient also today. She was telling me that she used Dr. Google for some kind of information. And I said, no. Making sure you have proven reliable sources for your information. Again, the NCCN is huge. American Cancer Society, NCI, National Cancer Institute, any of the big institutes like Johns Hopkins, Mayo Clinic, those are all great resources. Benefit from the experiences of others, but remember your path is unique. Again, like I said, you may have a whole group of apples, but you have different types of apples, even within the apple group, right? So your experience as a colon patient might be different from someone else. And choose a doctor you can trust and feel comfortable with. If you don't have that connection, you're going to be with this doctor for probably years. It's going to be a long-term relationship. So making sure you can speak openly and freely and have a good, strong sense of communication with that provider is important. Next slide, please. Okay. Okay, I'm done talking. If anyone has questions.
So I'm looking in the chat box and I'm not seeing anybody posting any questions. If anyone wants to go ahead and unmute themselves, if you have questions, feel free to do so now.
I am going to, can you hear me? This is Beatrice.
Yep.
I am going to have to leave the meeting. I thank you very much. It was such an amazing overview. It was quite a trip.
Oh,
Yeah.
Thank you.
Yeah.
I'm glad you came.
Yeah, it was an emotional journey, and I do appreciate your presentation. I'm on my way out. Thank you.
Oh, thank you. Have a good day.
So So I'm still not seeing any in the chat box. I know Donna covered a lot, but if no one has questions, the presentation will be posted on our YouTube channel. If you would like it emailed, just say so. You can put it in the chat box. Also, you guys will all be emailed a survey to kind of go over how this went today and give us your feedback. And yeah, I think that's it. Thank you all for coming.
Thank you.
You.
Thank you.